Okay, I like to do things on time, so it's 1 o'clock. Sorry, 2 o'clock. So I'd like to welcome everybody to this webinar session. This is the first in a series of 6 sessions on dementia. This series is brought to us through the courtesy of a grant that NAJC received from the Sephardic Foundation on Aging. We are so grateful to them for all that they've done. They're allowing us to do this. Has been absolutely wonderful, and it's really appreciated. Just to let everybody know, we want to thank everybody for coming. We are going to have webinars on each of the next five Mondays, with the exception of November 14th. November 14th, we're taking a week off, and our series will conclude on December 5th. Next week's session is again going to be on Monday at 2 o'clock Eastern. Our guest is going to be Rabbi Dale Friedman. Rabbi Friedman has written extensively and has worked extensively in the geriatric field and is an expert on dementia from a chaplain's perspective. She is a chaplain. She's a board certified chaplain, and she's been involved with NAJC for a number of years. Her presentation is going to be called A Journey of Dementia, The Journey of Dementia Through a Jewish Lens. And we certainly encourage and invite everybody to be involved. Today, we're going to be looking at the medical aspects of dementia. We're going to find out what dementia is, how it affects people, and our subject matter expert is Dr. Mark Agronin. Dr. Agronin is on the staff of Miami Jewish Health. He has written extensively. He has done a tremendous amount of work in this field, and we are very, very thrilled that he was able to join with us today. So it's my pleasure to give you Dr. Mark Agronin.
Rabbi, thank you so much for the introduction. It's my pleasure to be here. I'm really looking forward to the presentation and having some good discussion afterwards. So with that being said, let me begin sharing my screen and we'll get started. And Rabbi, if you could just confirm whether you can see the first slide.
Yes, I can. Thank you.
Okay. So again, welcome everyone. My name is Dr. Mark Agronin. I'm a geriatric psychiatrist. I've been at Miami Jewish Health for the past 23 years, right in the heart of Miami. Miami Jewish Health, and originally about 80 years ago, was founded as the Jewish nursing home in Miami. Since then, we've grown, evolved, changed in so many respects. We're now at our heart is a 22-acre campus in Miami with nursing home, rehab, hospice care, independent living, assisted living, and what's called Mind Institute at Miami Jewish Health, which is the memory disorder center, which I founded when I first came here about 20 years ago, and which has a focus on comprehensive assessment and management of individuals with Alzheimer's disease and other neurocognitive disorders, as well as a very busy clinical trials program and some other really innovative programs I'm working on. So my focus day in and day out is working with aging individuals, primarily those with neurocognitive disorders and associated psychiatric conditions, but also with many older individuals who just have primary psychiatric conditions. So the talk today is entitled Medical Aspects of Dementia, What Chaplains Need to Know. In essence, I'm going to take you on a journey through aging, the aging brain. We'll talk about what is a neurocognitive disorder, what we also know as dementia. What's the state of the art in terms of our knowledge today? What are some of the main issues that you might encounter or at least should know about as a chaplain? And I'm also going to spend time talking about aspects of aging that often get lost in the shuffle, but are important to understand and to help balance what's typically a very dismal view of aging. So lots of topics to cover. We'll do this in about 45 minutes, and then we'll have time for question and discussion. So I'd always like to begin with a story, and this is a story about aging that will bring together the core themes of the talk, but most importantly, will give you a perspective on aging, which I've come to understand myself after many years of working in the area of geriatrics. And that really sets the stage for everything we're going to talk about today. So the story is about a renowned French artist born in 1869. He was most well known and came of age in the world of art in the early 1900s for his bold use of color and abstract shapes. And you can see this is a uh, image I've taken the liberty of superimposing a photograph of the artist standing on a ladder in front of a large, colorful canvas. And he was known for these large, vivid works of art that had a lot of motion built into them. And he was a very physical artist in terms of what he created, and probably hit his peak in the early 1900s in terms of how well known he was as an artist. As he got into later life for him, 1941, so at that point he's in his early 70s, he developed a severe abdominal ailment. Some people have said he had a duodenal cancer. That's the standard approach. Unclear exactly what he had, but the bottom line is it's 1941. It's war-torn France, overrun by the German army. Friends and family and colleagues of his are either in hiding, in exile. His daughter had been picked up by the Gestapo for working in the French underground and was almost tortured to death. His wife had left him. He pretty much was bereft of almost everyone and everything at that point, and he was facing a severe illness and had to have a surgery. Now, in 1941, having a major abdominal surgery had severe risks. There were no IV fluids at the time, or at least not ones being used regularly. There's no antibiotics being used regularly. So, literally, this was for him probably an endpoint. He was maybe the equivalent to someone in their 90s today facing a very severe illness. And in fact, he had surgery, he survived barely, but really waxed and waned in delirium near death for weeks and months. Was pulled through by very dedicated groups of nurses, and they called him Le Ressuscité, literally the man who returned from the dead. But he was bedbound. Maybe they could get him into a wheelchair eventually. He was not about to get on a ladder and do the type of art he did before. In fact, he figured this was the end of his life. He survived, but did not anticipate living much longer. That was how he looked at it. Those around him looked at it that way. He had a long recuperation in front of him at a very difficult time without the sort of resources that we take for granted today. In a real low point for him, he's bedbound, unsure whether he can even do art anymore, in the throes of what we'd say is old age. He had a memory from the past. Something came to him that proved to be life-altering. And the memory was when he was an adolescent and he had what probably was appendicitis. He was back then, this is in the late 1800s. So if you were ill, they put you in bed and hopefully you recuperated and got out of bed. There's not a lot more they could do. And during his long convalescence, his mother really took such pity on him, was so upset over this that she brought him a small gift. And she gave him, it was a little wooden box. And when he opened up the box, in front of him was a small easel, some paints, some paintbrushes, and a little canvas. And it was the first time he ever began to create art. And he wrote later that he felt like a wild animal because he was free. Even from the confines of his bed, there's so much he could do. And it's interesting that his group of artists many years later were called like the term wild animal because of the exuberance and of the art that they created. But for him, now many years later, laying in bed, convalescing again, he realized, well, if he can't go to the art, maybe the art can come to him. And so he began from the confines of his bed to write little postcards to others and illuminate the postcards. And he then developed an idea with the assistance of a very dedicated assistant who still worked with him to have her take sheets of paper and paint these vivid colors on them and bring him the sheets of paper and scissors, and from his bed or from his wheelchair, he would cut out shapes and paste them in booklets or have her paste them on the wall. And he literally created a new form of art using these colorful paper cutouts. And here you can see is a photo of him in his wheelchair with all these cutouts laying on the ground in front of him. You can see on the back wall is one that was pasted up. He illustrated a book called Jazz. This is an image from that book. And when you think about jazz, it doesn't necessarily connote old age. We think of jazz in terms of liberation, improvisation, freedom. That was what old age was becoming for him, really contrary to what people would have imagined. So his second life, which he envisioned would be a few months or maybe at best a few years, starting in 1941, he actually lived until 1954 and was quite productive and literally revolutionized the world of art and later fashion, advertising, with these bold, colorful paper cutouts. This is an artwork of his called Le Gerbe, which in French refers to a sheath, like a sheath of wheat, which typically we would imagine as a very colorful, closely bundled stack of wheat. For him, you can see it's explosion of color and of form and of movement, because that's what was going on in the work that he was created. I don't know if you know who I'm talking about. This was none other than the great French artist Matisse. And he talked about this second life as being a true gift for him. And he famously said, I have needed all that time to reach the stage where I can say what I want to say. For Matisse, aging was not the problem. Aging was the solution. Aging gave him the courage, the insight, the foresight, the creativity to do something that was really revolutionary at a time when most people don't see aging that way. And so the core lessons here that we can pull out of the life of Matisse, but I would argue out of the life of any aging person, all of us included, is that aging brings strength. We're so focused on how we define aging and everything about it as all being about decline and deficits and decrepitude and disease and eventually death, that we don't often look beyond that. So as a chaplain, as a clinician, as a doctor, whatever your role is, if you work with older individuals, when you walk in that room, your basic knowledge, notion, assumptions about aging, you carry with you. If it's all about negativity and death, that's what you're bringing with you. If we don't have a perspective that also considers the strengths of aging, it's going to be a major deficit. So we're going to journey down to the depths of aging, but we're going to come back to talk about the strengths and what we learned from Matisse, because the main challenge we all face is not everyone believes that aging brings strengths. So I do feel I do need to prove that to you, but we're going to take a little side journey first and talk about Alzheimer's disease and what it means and things you need to consider, and then we'll come back to this. So there's a really provocative article that came out in 2014 in The Atlantic by the well-known medical ethicist Ezekiel Emanuel, and it was entitled "Why I Hope to Die at 75." And amidst many other things, he wrote, "Death is a loss, but living too long is also a loss. I would no longer be vibrant and engaged, but feeble, ineffectual, even pathetic." So he's not saying he's going to end his life at 75, but he said his plan is not to do anything to prolong it beyond the age of 75. Now, I'm not sure. I don't know how old he is right now. He's probably pretty close to that. I'm guessing maybe he's adopted a different approach. I'd be curious to see about that. But in any event, the bottom line is that he is describing an attitude a lot of people take, that, aging is great as long as you're not facing problems with it. And it gets to a certain point where, what's the point? And again, when we walk into the room of someone who is old and feeble, and if we see them as ineffectual, even pathetic, in the words of Emmanuel, the question is, well, what's the point? How do we see value there? How is that going to influence our decision making? And I want us to think very deeply about this. And to present this, these are very common attitudes. And I saw this played out in so many different ways, but this is actually a colleague of mine who turned 50, and they held a little birthday celebration for him, and they gave him this hat that says "Over the Hill," and it has attached to all these different accoutrements poking fun at different elements of aging. They gave him Dr. Decrepit's Over the Hill survival kit, the 50 Sucks candy flavored lollipops, the Old Geezer Lost Your Marbles replacement pack, and of course, I later, visited drugstore just to see all the cards about aging, and they basically poke fun at aging, portraying you as feeble, like a dinosaur, prehistoric, memory problems. And I thought, I don't think any of us consider 50 very old, but here it is. We're already at even a young age, we're beginning to give each other, ourselves and one another, these images of aging as a problem, as a disease, as something that's dragging us down. And my assertion is that there are consequences to this. It affects how we look at aging. It affects how we look at our own aging. And we really need to take note of these prevailing attitudes. The problem is that we internalize them, many of which are stereotypes, negative attitudes that maybe have some basis in reality, but do not tell the full story here. And the consequences can be great. So I want to explore first why we think this and give a basis for that before I give the counterpoint to that. So let's talk about the aging brain and the aging mind and what's not working and what's changing, and why we look at aging from this negative perspective. And what it is at least important to understand about these changes, because obviously if you're working as a chaplain, you're working with individuals who are in pretty dire straits. So one thing we know about brain aging is that the general rules are as follows. Neurons, which are the stuff of our brain, the basic brain cells, they, as I put it this way, they get dirty, they do less, they die. What do I mean by that? As our neurons age, they build up more junk inside. They're less efficient at clearing out until, as a result, they don't produce as much neurotransmitter. The transport through them is slower. They're less energetic. Impulses are a little slower. This is responsible for why mental processing speed decreases with age. And the rule is generally neurons die. We lose them. And so the brain shrinks or atrophies over time. You can grow new neurons, but that's more the exception, not the rule. What we'll talk about is making connections, or synapses is where it's at. But if you look at an older brain versus younger brain, it's going to be more shriveled. That's just the bottom line, because we are losing to some extent the stuff of the brain. You can see in this image, you go from the image of a 30-year-old brain to an 80-year-old brain, and you can see how it looks withered. It's lost a lot of material. This is data from the Seattle Longitudinal Study in Aging. They looked at different age cohorts, individuals in their 30s up through their 80s, and they measured them on basic IQ tests, reasoning ability, verbal ability, spatial orientation, numeric ability, word fluency. And what they found is, in general, these cognitive skills peak roughly between the age of 40 and 60, and then they begin to decline, and with more severe declines once you get into your 80s. I could put up on this chart many different physical metrics, how fast your kidneys can detoxify your blood, same thing with your liver, your output of your heart, muscle agility, things like that. You're going to see similar downward curves. And so this is how we often write the story on aging, as our major faculties, both physical and cognitive, are declining with time. And so we define aging on that basis. Now, we'll come back to this in terms of what's missing, but that's a general attitude and approach that we take both scientifically and in many other respects on aging. If you look at research on cognitive changes, we see a division between what's called our fluid intelligence and our crystallized intelligence. So our fluid intelligence are things like problem solving and reasoning, logic, pattern recognition. We know that these cognitive processes begin to slow after the age of 20. Our processing speed, as I mentioned, is slower. We have more of these tip of the tongue lapses. You can just almost taste it, but you can't remember the word or the name. We also have more difficulty suppressing distracting stimuli. So, when you're reading something, different noises or interruptions or other things on the page tend to distract us more when we're older than when we're younger. And in general, we're slower and less efficient at multitasking. So this is really responsible for those downward curves you saw on the last slide. If you look at what we call crystallized intelligence, our basic skills, our knowledge, our experiences, this remains stable or increases over time. We're always learning and growing, hopefully. Vocabulary and overall knowledge increases. And so you have this point counterpoint where some things appear to be slowing and less efficient. Others are more stable or accruing over time. And so we have to keep in mind these two different processes with the aging brain. And what's normal? Well, as I outlined in the last slide, it's normal for memory processing to slow, have more tip of the tongue experiences. And we know that we're more vulnerable to the effects of medications, to insomnia, to stress in terms of our memory function. But ideally, the impact on our daily life is negligible. It may be annoying, but we still function and do what we need to do. That's what we consider normal changes. So when someone comes to me and complains about everything they forgot, and they recount everything that they forgot, and I realize it's more of a nuisance, but they're functioning basically at a high level and doing what they need to do, I'm not as concerned, because that's more normal changes with age. Just like we complain of different aches, pains, slowing in our muscles, which is more normal with age. But as with our body, the same with our brains, training can improve memory and cognition. No question about that. And other different training. We'll talk about what we call brain healthy lifestyle a little bit later in the talk. Why does memory fail us in these normal stages or in some abnormal sense? Well, if lots of different things. If you have hearing loss, you're not going to remember what you can't hear or see. If you're distracted or nervous or depressed, you're not going to have as good attention. If you are tired, you're sleep deprived, you're sick, you're taking certain types of medications that can impair cognitive processing. We also know that illnesses and medication effects can also impact accessing long-term memories as well. So those long-term memories are there, it's just more a matter of accessing them. So these are all, as you can imagine, correctable factors. And that's one thing to keep in mind. So when people come to me and they're complaining of memory issues or other cognitive changes, I first want to know what's going on transiently, acutely, that we can identify and reverse, because that can make all the difference. And one of the number one issues is have someone put in a good hearing aid. The main concern is, what if this isn't normal? So it's one thing to say someone has what we might call age-associated memory impairment. Just as it states, this is relatively normal for one's age. Some people have what we considered abnormal. So they're still functioning relatively normally, but if you compare them to their peers of the same age, they're more impaired. And we call this mild cognitive impairment. And it's somewhat of a warning stage, a doorway into more severe impairment, because as we'll talk about, this is a time when you want to catch what's going on. And then some people progress on to develop what we call frank dementia. We're going to define that. But this is really the concern people have, that with time we progress inevitably into dementia, which is not true, but there's a big high risk of that with age. So what's cognitive impairment? We call this, or MCI. People have self-reported or subjective memory complaints. When you actually objectively study it, you do see that their memory scores are lower than the average peer, but their daily function is essentially normal. And if we follow these individuals over time, we typically see that a third of them revert to normal over several years. There's some transient issue that gets better. A third develops some form of dementia that we'll talk about, and the remaining third remains stable. Now, this is not always the case. Every person's an individual, but it speaks to the fact that this is the point where you want to catch what's going on, because if it's something that's reversible, the longer you wait, the less reversible it becomes. So what do we mean when we use this term dementia? The term itself comes from Latin. Dementia means literally without a mind or without a brain. And it's an ancient term. Romans use this as a way to insult people politically. So just like people use today. So it wasn't just a medical or scientific term back then. And that's part of the problem, is that it has negative connotations. And so A number of years ago, the American Psychiatric Association renamed this major neurocognitive disorder. So we don't want to use the term dementia anymore. We want to get away from it. But basically, it's defined as a brain disease with impairment in one or more of the following cognitive domains: complex attention, that's our ability to multitask; executive function, that's how we plan, organize, prioritize, largely located in our frontal lobes of our brain; learning and memory, obvious; perceptual motor skills, so using and recognizing faces and maps, different items; language, both speaking and understanding what we hear; and social cognition, that's being able to act appropriately with others, to take note of our behavior, to self-regulate our behavior. So when someone has impairments across one or more of these that are sustained, we call this a major neurocognitive disorder. So it's not just all about memory. Memory and learning are often one of the most important and noticeable aspects, but it's not the only one. And there are different types of dementias or neurocognitive disorders. So a lot of people get confused by this. So think about it this way, dementia is like the category of infection. If someone says you have an infection, the obvious question is, well, what type of infection do I have? Is it a skin infection, pneumonia, an infection of some other organ? Similarly, dementia refers to the whole pie, all different types of impairment, with the most common type being Alzheimer's disease, which I'll define in more detail in a minute, roughly representing 60 to 70% of all cases. 15 to 20% of people with the type of dementia have what's called vascular dementia, so either due to stroke or some other damage to the blood supply to the brain, maybe from a bleed. There's something called dementia Lewy bodies. 10 to 15% of people have that. In some ways similar to Alzheimer's disease, also with aspects of Parkinson's disease. There's something called Parkinson's disease dementia, less than 5% of cases. Frontotemporal dementia, a form that's more focused on abnormal behaviors, another type which is more based on language, less than 5% in general. Though if you look at individuals in their 40 to 60s, you see maybe 20% of frontotemporal dementia. And then medically induced, so dementia due to trauma, toxins, illness. In younger individuals, this is actually the most common form or cause of a neurocognitive disorder from traumatic brain injury. Alzheimer's disease distinguishes itself in the sense that it's progressive. It affects the cortex of the brain. That's the part of the brain responsible for all our higher order functions. It typically begins with short-term memory complaints, but progresses on average over 8 to 12 years. It involves every cognitive domain. It impacts function, mood, behavior. We have existing treatments to modify symptoms, but not the disease itself, although we do have some emergent treatments we'll talk about. But look at the diagram. You can see of the whole pie that's called dementia, the biggest piece, the biggest slice is Alzheimer's disease, which is why it gets so much attention. And it's largely a function of age. So every decade you live, the percentage of individuals with Alzheimer's increases to the point where once you get to 85 and above, nearly 50% of the population has some degree of Alzheimer's disease. That's why we hear about it more today, because more people live into that age range. If you turn back the clock to the 1950s, the average lifespan was in the early 70s. And so many people didn't even live into the stage where they would develop Alzheimer's disease. If they did have a form of dementia, it was typically due to stroke, just because people back then didn't have as good control over blood pressure and diabetes. And we know that it's at epidemic proportions now. Nearly 6 million Americans have Alzheimer's disease. This number is going to more than double by 2050. 50 million people in the world have some form of dementia. This is going to triple by 2050. It's an equal opportunity disease. It doesn't matter where you live, what country, what culture, religion. Everyone is at risk for this. We only see it less in the less industrial parts of the world because people don't live as long, or there are other causes of cognitive impairment that they develop first. Deaths in the US that are attributed to Alzheimer's disease have increased by 145% since 2000. Again, because more and more people are living longer, healthier lifespans, but not in terms of their brains. And Alzheimer's disease costs the US economy almost $300 billion a year. This is more expensive than heart disease and cancer. So keep that in mind. And yet we put in maybe a quarter at most of the funding for Alzheimer's disease as we do for these other diseases. What are the most important risk factors for Alzheimer's disease? It really depends on what stage of life you look at. So we know that there are certain genetics, obviously, which have a big impact. Higher education earlier in life is protective of Alzheimer's disease. We'll talk about, I don't know if I have a slide on genetics, but there's certain genetic risk factors that can increase your risk. There are certain family groupings that have certain dominant genetic factors that can lead to Alzheimer's disease. In midlife, the main risk factors are hearing loss, high blood pressure, and obesity. And as you get into later life, the main risk factors are smoking, depression that's not treated, physical inactivity, social isolation, which is a big factor during COVID, and diabetes. And it's interesting to realize that about 40% of these risk factors are potentially modifiable. So we'll talk about a brain healthy lifestyle that can, for many people, possibly stave off the disease. So how do we know if someone has a major neurocognitive disorder? This is what we do at Mind Institute, at other memory disorder centers. When people come in, we do a comprehensive evaluation. So we get a good description of what's going on, a history of their symptoms, and really want to know what's changing over time. That's really what's most important. Where were they before? What was their baseline? And what's changed? We want to get a thorough mental status examination. That's asking them, how they're feeling, look at their mood, their behavior, their language function. We do some sort of brief cognitive test just to see where they're at. Physical neurological examination, basic labs, always need to get some form of a brain scan. CT scans are quick and easy and cheaper, but really MRIs are the most detailed scans. There's also different forms of what we call PET scans that can do things like show us how the metabolism of the brain is. They can show us if there's toxic proteins such as amyloid or tau, which we believe are responsible for Alzheimer's disease. And then finally, we often like to get more detailed intellectual testing or neuropsychological testing. It takes a few hours and it really shows us the spectrum and the degree of impairment. So one of the problems is that it often takes a long time for people to get an assessment. On average, individuals who are developing cognitive impairment actually don't even see a physician for up to 2 years, and often don't receive a diagnosis for up to a year afterwards. And what's really alarming is a high percentage of individuals, up to 20%, who actually have Alzheimer's disease, never even get a diagnosis in the first place. The reason why this is such a major problem is that, as I alluded to before, there may be reversible causes that become less reversible over time. Obviously, i.e. the damage is done. The longer you delay a diagnosis, there's going to be delays in treatment, in the opportunity to participate in research, to get assistance, to put safeguards in place if someone's driving, as an example. If you don't know what the diagnosis is, treatment can be misdirected, inappropriate, unsafe, and it might not be dementia. I've treated people who come in and they think it's dementia, or they've been diagnosed with it, and guess what? It's not. There are other disease states that are actually causing the problems, but they haven't got treatment for it. So that's why assessment is so important, and early assessment in particular. So what about treatment? What are the main goals of treatment? Obviously, Alzheimer's disease is progressive, it's incurable. So if you do nothing, you just get progressive decline over time. We do have certain medications in the market, something called Aricept, something called Razidine, something called Exelon, another one called Namenda. These can provide some degree of symptomatic improvement, but it's modest at best, and people continue to decline, but it still gives them some benefit. There are some new treatments we're studying. There's one on the market, somewhat controversial, but they have shown the ability to actually modify the disease, to slow down the course of it. And obviously, we want to get something effective that cures it, that stops in its track. That's where we're trying to head. And there's different approaches to treatment. So disease modification, which is the goal, there are a lot of treatments being studied right now. Only one's on the market, which is a form of immunotherapy. Basically, the theory is that you have a buildup of two toxic proteins in the brain, one called amyloid, one called tau. And we use immunotherapy to get your own immune system to target and break up and get rid of these proteins. And the data has shown that we can reliably decrease the amount of these proteins in the brain, and it appears in a certain group of people to slow down the course of it, but modestly, which is why these treatments are controversial. One came on the market and there's a lot of controversy about it because many scientists didn't think it was effective enough to be approved by the FDA. But we're doing lots of other types of studies to try to find ways to stop this disease, so far without significant success. As I mentioned, there are a number of medications on the market that can provide symptomatic improvement. But one thing I really want to emphasize is there is no magic formula. You will hear from people taking all sorts of potions and lotions and formulas. Maybe you yourself are taking a few on the list here, none of which have any significant data showing that they make a difference. The only people benefiting are those who are selling them. They're actually doing quite well. But aside from them, no one else is really getting much benefit aside from maybe a placebo effect. So what can you do to decrease your risk or to improve one's quality of life if they do have some degree of cognitive impairment is to adopt what we call a brain healthy lifestyle. Some form of physical exercise, moderate, most days a week. This improves blood flow to the brain. We release these neural growth factors that make our brain cells more apt to connect with one another. Physical exercise is, without question, the best and most supportive thing you can do. In terms of diets, there's a lot of craziness out there in terms of what people assert. The only thing that's really shown to have some robust data in terms of reducing risk and maybe improving modestly cognitive function is what's called the MIND diet. It's basically a Mediterranean diet, rich in fruits and vegetables, fish or olive oil, less high sugar and processed foods. If you, and I emphasize, if you already have a single glass of wine a day or a spirit, that's fine. I'm not advocating that people start, but in essence, that can be part of it. A lot of this is based on studying individuals in different parts of the world that live long and have very healthy lifestyles. And this is the type of diets they tend to eat, colorful diets. Brain stimulation can make a difference, stimulating games and puzzles, volunteer work, adult education, learning new skills or languages. There's no one thing that's magic. Some people say, oh, I do the crossword puzzle every day, or I do this puzzle or this game. That's great and it's good, but you really have to cross-train your brain as well. So if you went to the gym and all you did is work your biceps are going to be great. The rest of your body may be a little flabby. And we say the same thing with the brain. You may really have great vocabulary and certain skills if you do crossword puzzles every day, but what about learning a new language, getting out and socializing with people, doing volunteer work? There's so many other things you can do to stimulate your brain. And finally, we tell people you need to take good care of your brain. Adequate sleep, hydration, meditation, yoga, prayer. As a chaplain, you can really get someone into that. You can give them a boost by helping, supporting them, enabling them to pray, to engage in some spiritual activity. It can make a real huge difference for someone. So we've kind of taken this journey through the downside of the aging brain. Let's come back to what I talked about initially in a few minutes about what are some positive things. But before we get there, let me just say a few things about, what are some things as a chaplain you might encounter, some of the issues and what psychiatrists often do. There are a number of legal different aspects: informed consent, incapacity. What about when someone's terminal, DNR orders, advanced directives? And you may be called upon to participate in a discussion to help support someone through these decisions. So I want to put a little information on this just to that end. So, one major issue has to do with decision-making capacity. And this is what we call, capacity is a person's ability to make sound decisions with respect to specific issues. Capacity is for capacity to do X, Y, or Z. And it's based on a clinical examination. Competency is a legal term. So a clinician is never going to determine that someone's competent or incompetent. Only a judge can rule that. What we do is determine, does someone have capacity? And it may be capacity to make healthcare decisions, make financial decisions, to live independently, to participate in legal proceedings. Capacity is not necessarily a general term, but it's specific to certain abilities. And to determine this, we really look at what's going on medically with someone, psychiatrically. We do a mental status examination. We do some sort of memory screen. And we'll want to talk to the person about what's the particular issue that's at hand that they need to make a decision about. And we really want to know, can they tell the facts of the situation? Can they describe what their choices are? Do they appreciate their ability to make a choice? Do they know the consequences of not making a choice? You might not be, as a chaplain, involved in detail with these discussions, but even when you go in and you're counseling someone, you're trying to help them through a certain situation, it is important to have a sense for how well can they appreciate their current situation, how well can they understand, at what level can they engage in a discussion consistently with you. So these are also important things to be able to get a sense for in your work with them. And what are the main barriers to capacity? Well, acutely, someone's delirious, they're severely depressed, they're intoxicated, obviously. Chronically, as we talked about, major neurocognitive disorders will impair capacity. Also, someone who has an intellectual disability, a chronic psychotic disorder. So just things to keep in mind. So we have about 15 minutes left. Before we go into some questions and answers, I want to come back to that original issue that we talked about. And that has to do with how we define aging and thinking about aging only in terms of decline versus the fact that, as we saw in the life of Matisse, aging brings strength. So I want to ask you this question. I want you to think about this, and I'll carry this through the remainder of the talk. When do you think you made better decisions in your life? Now or when you were 18 years old? So think about that for a minute. Most people will immediately say, well, of course, now I make better decisions. And the question is why? The 18-year-old brain is about as nimble, agile as it's ever going to be. What are you missing at 18 that you have now, that aging has given you? And people will say, of course, experience, knowledge, all that stuff. So let's talk a little bit about that, because those are the strengths of aging that I'm referring to and that everyone has. So with time, even though we talked before about some of the things that you lose or decline with time, we also keep in mind that time also allows your brain to continue to learn, to develop. And we're always building up what we call our brain and cognitive reserves. And this is the total brain connections, our intelligence, our skills, our experiences. Our brains are constantly adapting and resculpting themselves. This is what we call neuroplasticity. How do they do this? Well, they recruit more brain circuits. They use both sides of the brains more. So these are actually changes in the way the brains function with age that gives an advantage. Younger brains tend to be more localized in terms of working on problem solving. Older brains tend to bring in more circuits, more regions of the brain, which is why we often look at decision making later in life as being more integrated and having a broader number of perspectives with it. And our minds develop new approaches. And so there's something called post-formal thinking, which refers to the brain's ability to think in more practical and more pragmatic and practical ways. We tend to be less reactive, less rigid, less impulsive when we make decisions later in life. And this is an advantage. There's also a theory called socio-emotional selectivity. This refers to the fact that we prefer more positive experiences and we gravitate towards more meaningful goals and activities as we get older. This is largely based on the work of the Stanford psychologist Laura Carstensen, but she's shown that contrary to this belief that older people tend to be more negative, more stuck in their ways, it's actually the opposite. People tend to be less depressed, more positive, more apt to look towards positive and meaningful things. And finally, this term developmental intelligence, coined by a well-known psychiatrist by the name of Dr. Gene Cohen. He talks about how as we get older, the older mind is actually able to combine our cognition, our emotion, our judgment, our social skills into a more balanced and integrated whole. And when you put these three scientifically proven developments together, this is really what we call wisdom. So we tend to think of wisdom often in a very narrow way. We think of King Solomon sitting on his throne and making these grand decisions. I mean, obviously, that's a big part of wisdom. And King Solomon was one of the wisest in history. But this is a way that we can really look at what the aging brain does that confers wisdom upon it. We know that wisdom grows and develops with life experiences, but it takes some work. We have to reflect upon it. We have to learn from it. We know that wisdom serves a higher purpose. Wisdom is something we can share with other people. And one important thing, and I learned this when I reviewed all the literature on wisdom, is that it comes in multiple forms, and I want to talk about that. So think about, how does aging change us? So we know time brings knowledge, experience, and skills. We learn lessons that enhance judgment and perseverance. We all face failures, and this leads to a sense of humility, gratitude, and empathy. We have ambitions, and this motivates us to create and build as we get older. And also the approach of death, it brings, in most people, a sense of acceptance, insight, and spirituality. So let me take out the key words here: knowledge, judgment, empathy, create, and acceptance. Each one of these represents a form of wisdom. And I've given each one a name in my book I'll talk about. Savant wisdom, sage wisdom, curator wisdom, creator wisdom, and seer wisdom. And one thing is that everyone has different forms of these 5 forms of wisdom. And so, for instance, the savant wisdom is someone like an expert, a master, a storyteller who just has this incredible accumulation of knowledge, of experience, or skills. Sage wisdom we find in mentors and coaches and docents, people who just have this broad and balanced perspective. They're people who can really give good sage advice, as we call it. People have curator wisdom, caretakers, judges, stewards, guardians, that have this empathy and caring for others and for cultural icons. Artists, craftsmen, explorers, hobbyists have creator wisdom, where they like to build, be artistic, innovate. And finally, individuals who have the seer wisdom, so volunteers, counselors, spiritual leaders, what all of you are doing, have this form of wisdom largely found in a sense of acceptance, of spirituality, of transcendence. And we all have different forms of this as we get older. And think how wonderful it would be as you turn 60, 70, 80, instead of people giving you these silly gag gifts poking fun at aging, then instead they talk about all the different wisdom you have and the attributes you have and what aging has given you and accruing you and still building as you get older. The key thing is, when you go into work with someone, especially those with neurocognitive disorders, can you find the wisdom in them? Can you see it? Can you share it? Can you elicit it from them? Because even in that stage, wisdom is always present. So people who are more debilitated, their presence may be the substitute for what they can perform. The process of them connecting with you or connecting through art or something is a substitute for being productive in other senses. And so there are people who have savant wisdom by virtue of being a witness to history or a repository of some story. People who have sage wisdom because they're the matriarch or patriarch of a family. It doesn't matter what they can say or necessarily share actively. Their presence alone is the glue that holds a family together. People who have this curator wisdom regardless of their physical or cognitive abilities, they're cultural icons. They stand for something which is so important to us. People always retain a sense of creativity, even in later stages of Alzheimer's disease. It's sometimes we need to help them to be artistic, to tell stories, to engage in something, and what comes out of them can be amazing. And finally, people who have seer wisdom, they may be almost like a relic to us. There's something about them which is so important, so holy. I've been in Hasidic communities where you see the Rebbe, regardless of age or ability, is so revered. Their presence is so inspirational for people, and you find that across many different religious traditions. So the point being that wisdom is always present. Sometimes we need to look a little harder and have to elicit and prompt it to really see it. We know that people who are aware of their wisdom, they share it. They have increased well-being, better life satisfaction, better family relations, marital happiness. They adjust better to aging, and they have lower levels of depression. So with that, I think you've seen the whole spectrum of how our aging brains and minds change in ways that are both, excuse me, positive and negative. We've talked about what is dementia, now we call major neurocognitive disorders. What are the major types, how we work it up, how we treat it. And the main theme I've wanted to incorporate this, going back to the story I began talking about Matisse, is the fact that even in the most debilitated of states, we always have to keep in mind what strengths are there, the wisdom, the abilities, the humanity. Once we lose track of that, it's more difficult for us to really be effective in terms of making a meaningful difference in someone's life. Everything I talked about today is found in one of 3 books I have, one called How We Age, the other called The End of Old Age, and then a book called The Dementia Caregiver. So easy to get them on Amazon. And with that, I apologize. I've had bad allergies today, so forgive me for my frequent coughing, but I want to just thank you again for your attention, your time today. I hope this has been instructive, and I'd be happy to answer any question that you have.
And attendees can submit questions through the Q&A button at the bottom of the window, and we're taking them now. Thank you. No, if you're
So before, but while we're still waiting for questions, let me turn around and ask Dr. Agronin a question that crossed my mind along the way. You began to talk about capacity, about an individual's capacity to do things, and I know that oftentimes we talk about a concept called competence. Capacity, to my understanding, and please correct me if I'm wrong, capacity is something that medical experts certainly talk about. Competence becomes a legal state that only a court of law can confer. So it doesn't behoove us to turn around and say this individual is competent or not. We can say that somebody has capacity. We feel that somebody has capacity.
Yes, that is exactly true. And it's capacity to do something. So, when someone says, oh, does this person have capacity or not? The question is capacity for what? But you're right. Only a judge can determine competency. Now, he bases that on the opinions of clinicians who
Correct.
give recommendations on the person's capacity, but it is a legal term. That's very true. Unfortunately, it's thrown around. People say, oh, someone's not competent to do this. It's really what they mean is they don't have the decision-making capacity to do this. And it can vary. I mean, there's some people who maybe don't have the capacity to make detailed decisions, but can make more basic decisions. And that's what we have to try to determine. And it can be complicated.
Allison,
all right. Well, we have a number of questions. Do people with reduced executive function, such as ADD, have a higher chance of developing dementia?
Do they say reduce executive
Executive
capacity with
function,
with ADD?
ADD. Mhm.
Oh, so attention deficit disorder can persist into adulthood. It is not considered a risk factor for Alzheimer's disease or any other form of dementia. I've seen people misdiagnosed because they have adult ADD and not dementia, which is why the testing is so important for it. But no, it's not considered a risk factor.
Thank you. Can you speak to the process when a person knows they are in the disease process? That transition point of awareness to beyond is really hard. Any thoughts on how to be present for people in that space?
So people have varying degrees of insight into their difficulties. I often find in Alzheimer's disease, insight goes quickly. And so I will meet people who have pretty significant memory and other cognitive changes, but they're oblivious to it. I often find when someone has had a stroke or, some other form of injury to the brain, they're more aware of it and more frustrated with it. And I always say you have to meet someone at where they're at. If someone is oblivious to it, reminding them, telling them, berating them with them, and it's not necessarily going to help or make a difference. It's just going to annoy them or alienate them from you. You really want to ask someone, what do they notice? Are they aware of anything? How do they feel about it? And go with that. It's a challenge doing an evaluation when people are doing things that are getting themselves into trouble. They're giving away money inappropriately. They're driving when they shouldn't be. I work with someone who insists on going to stores and will constantly shoplift from the stores because he just has no concept that he can't just take something from a store. And it's difficult, it's frustrating. Individuals like that, even telling them is not going to make a difference. Sometimes you have to impose restrictions on them to keep them from harming themselves or other people.
Thank you. Dr. Agronin, there can be great pressure to de-prescribe in the nursing home, which can push folks to discontinue dementia meds. Do you have any guidelines available for this?
Well, there's no question that a lot of the prescriptions in nursing homes for behavioral problems are not done by psychiatrists or people who are experts. And so, unfortunately, a lot of people do get put inappropriately on medications or too much medication, or it's just not managed appropriately. And so I would say the key thing is always make sure it's an expert who's the one doing the prescribing. I mean, just like you wouldn't go to a podiatrist to handle your heart failure, why have someone who's not a psychiatrist or at least has psychiatric training to work with very potent medications to deal with very complex behaviors? So that's number one. You always have to push for that. Some people just have knee-jerk reactions just because it's a psychotropic medication. They don't like it, or it's mind control or something like that. And that's unfortunate because some people do need the medication. Depression, anxiety, agitation, these are forms of mental suffering. And why should we let people suffer? It'd be like saying, oh, they don't need their Tylenol. They can deal with it. Or, why are you going to give them that body altering medication, the Tylenol? They don't need it. Well, that's cruel. You're having someone suffer. Depression is an enormous amount of suffering for people. It can lead to self-injury and suicide. So in those situations, we have to be very vigilant. And unfortunately, there's this prevailing sense that just because someone is old and has Alzheimer's disease, that we shouldn't use medications on them sometimes. And that can be also a detriment, or we need to take them off the medications that can really help them and make a difference. So again, put it in the hands of experts who know what they're doing, know how to use the medications, and can use them appropriately.
Thank you, Dr. Agronin. There's another question came up. Can you possibly speak to some practical ways that chaplains or other professionals can interact with patients with dementia? What tools might be most effective for engagement? For example, music, sensory objects, photographs, images.
So I don't know if everyone's ever had the experience of walking in and thinking someone can understand your language and you speak to them and they have no idea what you're saying. Or you think someone is hearing loss, you're speaking to them very loudly and they can hear exactly what you're saying. It's embarrassing, and basically what it's showing is that you're not being understanding of who they are, what their situation is. I would say in this situation, you need to understand what is dementia. What does the person have? What's the degree? because otherwise you may talk above someone or below them. You want to get a sense for where are they at, and that's going to give you the best guide towards what's the best way to communicate towards them. So someone who has moderate dementia, if you sit down and have a complex discussion of the meaning of God, it's going to be meaningless to them. That might be the person who you simply hold their hand and pray with, or sing with, or in that sense, sensory abilities, long-term memories can make all the difference. I remember when I first came here, I would go to the Minion here, and there were men there who I'd see in the clinic, and they had very little short-term memory, but they could run circles around anyone there because they knew this stuff inside out, upside down, backwards, forwards. It was so overlearned for them. And in that situation, they gave them a sense of competence, a good feeling. And so sometimes getting to know not only the disease, but you have to know the person. What is their background? What are their strengths? What is their history? And that can be a guide towards knowing what they're going to like and know. It's important today because, someone may be more or less observant than you are, or they, right now you may walk in with a 30-year-old sensibility to someone who's 80 who comes from a different world in a different sense. And, by forcing or pushing something on them can be problematic. Obviously, that's why politics should never be involved in this, but you really have to understand and respect where someone comes from, what's their background. I mean, another interesting story, I remember when I first came here, there were still battles between people who had a Hasidic philosophy and the, Misnagdic philosophy. Well, if you don't understand that, you're going to see these men fighting and have no idea what the context is of it. So again, knowing the history, the background is really important. I always tell people, do homework before you walk in and meet them. If you just walk in cold, there's a higher risk you're going to not be able to be as empathic and as effective with them. And part of empathy is asking questions. If you don't know, ask. Open-ended questions. Get to know the person just without any presuppositions and get a sense for where they're at and use that as a guide to where you're going to go with them.
Thanks. And oh, by the way, we're going to be having a session in a couple of weeks called Spirit Alive, which is going to talk about specifically this: how do we approach people with dementia? In fact, the next couple of sessions with Rabbi Adres and Rabbi Friedman are all going to be around this topic. So it's certainly an important topic, and that's one of the things that we want to do here is see how can we best meet the needs of people with dementia and their families. And oh, by the way, it's more than just saying let's have a Kabbalat Shabbat service or some kind of a service. So we have that. Doctor, somebody's asked, how do you find the balance between presenting a strength-based approach to aging and living with dementia and acknowledging the deep sense of loss or devastation that these individuals may feel?
Well, we always lead by listening to someone, hearing where they're at. So someone who is focused on the losses, we want to listen to them, acknowledge that, and not just respond in a way that's comes across as Pollyannish or in denial or just saying, well, but you can do this and this and that. It's really, I would say the first step is making a connection with them, just being present with them, having your presence be reassuring, comfortable for them, listening to them, learning about them, and let that be the guide. So you're basically, it's a process of empathic interaction that's going to help determine your next behaviors. So I tell people, don't come in with an agenda until you connect with the person and get to know them, because your agenda may then have to fly out the window. It may have no applicability then. That's really the approach you have to take. Someone who walks in already with a set agenda and assumptions and all that, they're doing for themselves and not doing really for the other person.
Perfect. Thank you. So one of our participants asked, how's Parkinson's dementia different from other forms of dementia?
Well, about 40% of people with Parkinson's disease over time develop some degrees of cognitive impairment, and typically it involves slowing down of mental processing. Their thinking is slow, just like their bodily movements are slower, their thinking is slower. So it may take them longer to process something. You have to be more patient with them. Their voices are not as loud, and so often you have to listen more carefully. There can be, they're not able to modulate their face as much, and so sometimes you're not always aware of the emotions behind it, so you need to ask about that. Sometimes people with Parkinson's disease can have hallucinations or unreal thoughts that are bothering them, and so it's important to understand that, to be able to reassure them, to be present for them. But those are the kind of the typical picture of someone who has a Parkinson's disease dementia.
One individual would like to know, how's drug research going, and when do you think we'll have medication to treat the disease and not the symptoms?
Well, on the one hand, we've made great strides in understanding Alzheimer's disease and understanding the presence and the role of what we call amyloid plaques and tau tangles in the brain. We developed immunotherapies that can attach to and help the brain mobilize and get rid of these proteins. The problem is people don't get better. So we made great strides in terms of our understanding and our targeting. We've not made great strides in getting people better. So it's frustrating. And that's why even the last treatment has been so controversial. I think it's going to be many years before we have a cure for Alzheimer's disease. And I'm right in the thick of research. We do all the major clinical trials, and we're struggling, I'll put it that way.
Somebody else is asking, do we find that people who have a history of concussions have an increased likelihood for Alzheimer's or some sort of dementia?
If it was a severe concussion with prolonged loss of consciousness, there is a slightly increased risk later in life, yes, of dementia. If it was repeated, what we call, in terms of, chronic, traumatic injury to the brain, people can develop what's called CTE, or chronic traumatic encephalopathy, like we see in aging football players and other sports figures. And that's a specific form of it, but that's more the exception rather than the rule. A single concussion when someone's younger, a brief loss of consciousness does not really increase your risk.
Thank you. And I think we have time for one or potentially two more questions. One person is asking or saying that she's a facilitator to get to caregiver support groups. What would you say to those caregivers based on today's presentation?
Well, I would tell them that a few really important things. One is it's important to stay on top of what's going on with the disease state that they're dealing with. It may be Alzheimer's, maybe Lewy body disease, but they really need to be educated about it and really understand it well and know what's going on with it. They have to take care of themselves, assess their own burden, their own depression. We know that caregivers have increased rates of depression and even mortality. So they have to find ways to take care of themselves, have time away, have enough supports, don't go it alone. There are a lot of resources in the community. And to find ways to be positive, focus on quality of life. Because in an era where we don't have a cure for this, we're dealing with this over many years. It's a marathon, not a race. There's still a lot that can be done to improve quality of life.
Thanks, Doc. And one of the things we're going to be doing over the next couple of weeks is looking at how can we help the families of people with dementia. How can we help them deal, because there are all kinds of strains that they're feeling as well, and we have to be there to be able to reach out to them.
So
And
one of the most effective things is usually when we meet a caregiver, we're talking all about the person, with the Alzheimer's or whatever. And I always say, then at some point, take a step back and say, how are you doing? What can I answer for you? Focus on them. That's really critically important. And let them know that they're a part of this and they're important as well.
Somebody's asking, what advice can we offer to patients and families to help navigate the difference between medicine-based symptoms and actual decline?
Read that last one again.
What advice can we offer to patients and families who are navigating the difference between medicine-based symptoms and actual decline.
I'm not sure I quite understand that.
And I'm just reading the question here again. So I think what this individual is trying to ask is, sometimes we have patients who will have symptoms that are based on medicinal symptoms with the medications that they're taking. Other times you have people who have actual decline.
I gotcha. Yeah. So this is okay. I understand. So this issue comes up all the time. This is where knowing the person and their normal state of affairs and their baseline is so important, because we're looking on the timeline. Does something change quickly or not? Usually the decline is something that happens more, it's slow, it's subtle, unfolding over weeks, months, over the course of a year. When someone changes an hour over the course of a day, a few days, you're worried about something more acute, an infection, a medication effect, something like this. So it can be hard to tell. This comes up all the time, but that's who, you have to really be vigilant. And I always err on the side of caution. If you're concerned, check a urine, check blood work, have them see their primary care doctor, things like that. Don't always assume it's just part of the disease.
Sure, perfect, thank you. And then the last question I have is, somebody writes, one of my Parkinson's disease patients has apparently Lewy body dementia. Can you explain what Lewy body dementia is?
Sure. So Lewy body dementia, like Alzheimer's disease, you get abnormal deposits of a toxic protein in the brain. So, a different type of rust building up than Alzheimer's disease. But Lewy body disease has very specific symptoms, which makes it so maddening. There's absolutely no cure or treatment for it that's effective. People often have fluctuating symptoms. So they'll suddenly be disoriented or confused for a few hours, a day or two, or they'll be out of it or look like delirious, and then they'll kind of snap back. And it's very confusing because you think something happened, there's episode, maybe they had an infection, to our question a minute ago, but it's because of the disease state. They're very sensitive to medications, especially psychotropic. So you give them a medication to calm them, and suddenly they sleep for 48 hours, or they have some unusual symptom. That's classic for Lewy body disease. People have vivid visual hallucinations often. They'll see little people running around the house. They'll be tormented by that. They have delusions where they think this is not my home, you're not my spouse. And over time, they develop slowing of their movements, as you see in Parkinson's disease. But it's the reverse. Parkinson's disease, people have slowing of movements and all the movement symptoms, and later develop the dementia symptoms. With Lewy body disease, it's the opposite of that. And the challenge is that the medications used to treat these symptoms sometimes make it worse. Sometimes people also act out their dreams at night. This is called REM, sleep behavior disorder. So those are all clues to this could be Lewy body disease compared to Alzheimer's disease.
Well, thank you so much, Dr. Agronin. I really appreciate all the time that you've given us today. I just want to tell everybody who's here, and we're certainly going to be letting everybody else know. If you registered for today, you registered for all 6 of these. You've registered for the entire series. So you'll so we're going to notify you continuously about the different sessions that are coming up. We thank you very, very much for your participation. And before you log off, there's going to be a quick evaluation of this session. We ask that you please take that, because that's going to help us give the feedback that we need to our sponsor, to the Spartak Foundation, who's made this possible. Again, thank you all for coming. Thank you to Dr. Agronin. Big thanks to Allison for all that Allison does. We're grateful to all of you. Be well, and we look forward to seeing you next week. Thank you so much.
Thank you. My pleasure.